يا دكتور.
لا العفو. You are recording. Make sure everyone knows they're being recorded. Okay. يا ريت نعرف. اوكي. طيب. زي ما قلنا ده النورمال بريست عبارة عن لوبيول مدورة كبيرة كده فيها أسيناي، والأسيناي دي بتسكريت ميلك. So how come that this milk will be conveyed to the nipple for the baby to suck? Through the duct system. ففي duct جنب اللوبيول. ده النورمال. يبقى إذا عندنا two important components في البريست. The lobule that secretes milk and the duct system that conveys the secreted milk to the nipple for the baby to suck. Next. هنبتدي بال benign tumors of the breast. ودول من أهم الحاجات اللي ممكن تقابلنا in our daily practice لأنها it's a common disease, it's a common tumor. Usually it affects young females يعني starting from 15 up to 25 or 30. ده الage range بتاع الفايبروادينوماز in general. They are totally benign tumors ما فيهمش أي risk for malignant change. What are the subtypes? Fibroadenoma is the first benign tumor, and its subtypes are called the pericanalicular and the intracanalicular. بعد كده هناخد duct papilloma وهنعرف الفرق ما بين ده وده وازاي ايه الريسك بتاع كل تيومر فيهم. يبقى نبتدي بالفايبروادينوما. Next. ادي منظر الفايبروادينوما of the breast. It's a very well localized capsulated tumor زي اي benign tumor انه لازم يبقى capsulated. It does not infiltrate the surrounding tissues. بالراديولوجي we will see it very highly calcified او very evident by radiology. في الباثولوجي بقى when we cut it, it is firm rubbery. بيسموها mouse of the breast. يعني ايه mouse of the breast؟ excuse me. mouse of the breast يعني لو حب حد يمسك فار مش هيعرف لأن الفار بيجري على طول. ادي منظر الفايبروادينوما because it is not infiltrating and anchoring the surrounding breast tissue, so it is freely mobile in the breast tissue. ودي برضو من ال characteristic features of any benign tumor انه capsulated, well defined and freely mobile. بعد كده next تحت الميكروسكوب هنشوف ايه two types that we mentioned: pericanalicular fibroadenoma and intracanalicular fibroadenoma. The one on the left, or two pictures on the left, are for the pericanalicular fibroadenoma. يعني ايه؟ هو التيومر اسمه fibroadenoma, so it's very evident انه في two components: fibrous component و epithelial component, adenomatous component and mesenchymal component. الصورة اللي فوق بتورينا إنه very regular ducts intervened by fibrous stroma. Both of them are intermingling and of equal proportion. يعني لا ده أكتر من ده ولا ده أكتر من ده. آدي البريكاناليكولر. نيجي بقى على الناحية اليمين اللي هي الانتراكاناليكولر. ليه اسمها كده؟ Because there is overproduction of the stromal issue أو fibrous tissue, so that it compresses the ducts and appears as if it is inside the duct. كل duct من دول بقت compressed, so it is as if forming a wall of a certain area. الحقيقة مش كده. الحقيقة إنه الducts كلها free من جوه بس هي compressed, and it appears as if the fibrous tissue component is inside of it. عشان كده سموها intracanalicular. So يعني simply speaking, pericanalicular is formed of two components, both of equal proportion. Intracanalicular, two components برضو, but the fibrous component is more predominant, so it compresses the ducts. الاثنين benign. Next. More example of the intracanalicular عشان نفهمها أكتر. شايفين الducts compressed but free. وintervened أو زنقت فيها incorporated the fibrous tissue. في ناس عايزين يخشوا المحاضرة، أنا شايفة فيو لوبي، في ناس هيخشوا واللي يخش يخش يعني مشكلة. أوكي next يا جماعة. في variations بقى in the fibroadenomas. ليه؟ Because the fibroadenoma is a benign tumor. It slowly progresses or enlarges. It does not cause much of an aggravated symptom for the patient, so the patient is not worried to seek medical treatment. The tumors زي كده can stay for months and even years without people seeking any medical advice. So they are exposed to being degenerated. Variations in the fibroadenoma will include many types of degenerative features. Hyalinization, calcification, ossification لحد ما تبقى عظمة حتى. يبتدي يحصل فيها joint cell reaction, maybe foreign body joint cell reaction, or it can incorporate some fat, muscle, or cartilage tissue. Sometimes it undergoes myxoid degeneration or becomes secondary infected. You see inflammatory cells, or may be traumatized and cause intratumoral hemorrhage, still benign. أو ممكن يحصل فيها cystic change. Apocrine Metaplasia or lactational changes دي حاجات بتحصل during lactation, because as you know, breast is a modified sweat gland, so as if it is secreting like sweat, but this, in this example, of course, it's milk. So it can undergo apocrine or lactational changes. لو الست بترضع, the tumor itself can undergo lactational changes, just like the adjacent breast tissue. نيجي لآخر نقطة, malignant change. Please, if you forget it, يكون أحسن. Malignant change is very, very rare in fibroadenomas, down to 0.1%. And if it changes to malignancy, it is going to be a carcinoma. يعني the epithelial component will undergo malignancy. Please don't mention this unless you say that it is very rare. ليه؟ فالحمد لله fibroadenomas are very, very frequent tumors. So it's good luck for the patient that she will not develop a malignant tumor. الفاريشنز تحصل او الديجنريتيف فيتشرز تحصل بالفريكونسي اللي احنا حاطينها في الاول, هايناليزيشن وكالسيفيكيشن, يجي بعد كده ميكزويد, cystic, hemorrhage, and last but not least at all, malignant change. Next. Now the next benign tumor, احنا دلوقتي خلصنا الفايبروادينوما. The next benign tumor is called the duct papilloma. في حوالي 16 ducts they open into the nipple for the baby to suck the milk. These 16 ducts coalesce from minute ductules in the breast tissue. يعني there's a very wide branch of ductules that coalesce together to form in the end 16 main large ducts opening into the nipple. هنا بقى هنبص نلاقي ان الدكت بابيلوما is always related to the nipple area. السكوير اللي محطوط ده عبارة عن الحتة اللي فيها الدكتس. Next. Sometimes the duct is very much dilated because there is a tumor inside, and this tumor is a papilloma. خدنا البابيلوما عادي في الجنرال. So it is kind of a tree-like configuration of a papillary tumor lined by benign cells and dilating the duct, and it causes what? It aggravates the female very much, because what it causes is bleeding per nipple. لازم نفتكر duct papilloma يعني bleeding per nipple. عشان كده الtumor is very small, although it is small, but the patient will always seek medical advice. ليه? Because there is some symptom that she fears, اللي هي bleeding per nipple زي ما احنا شايفين. Next. Okay, so duct papilloma. نقول بس كلمة على duct papilloma. ممكن ترجع تاني يا محمود؟ مش مشكلة. الduct papilloma ليه بتعمل bleeding? Because the papillary structure is formed of what? Is formed of a projection lined by a single or two epithelial cells, where lining what? Lining a very vascular fibrous stroma أو papilla. So if trauma occurs or for any reason, this epithelium is being eroded. So what is exposed is the fibrovascular core connective tissue. And the bleeding occurs or is poured out of these vessels where up to the nipple and outside. فعشان كده الدكت papilloma will cause bleeding per nipple. Next. كده يبقى احنا خلصنا يا جماعه البناين تيومرز فايبروادينوماس بانواعها وبعدين الدكت بابيلوما. Now we shift to another disease. It's not a tumor, but it's a very important disease again because it's frequently met with fibrocystic disease or the other nomenclature mammary cystic hyperplasia. This disease is usually due to high estrogen and it has several criteria. And from the name again, you can expect that it is a disease with cysts, with fibrous tissue, and with some epithelial component. So there is duct formation, and these ducts, when they are enlarged inside the breast, they form what's called blue cysts. Lay because there's tension fluid inside, so it reflects the color as if it is blue. Apocrine Metaplasia هنشوف الإكزامبل بتاع الأبوكراين ميتابليجيا اللي اتكلمنا عليه because breast is a modified sweat gland. And then there is fibrosis of the stroma, maybe calcification, inflammatory cells. But what's most important is the epithelial component. This is called ductal epithelial hyperplasia أو epitheliosis أو papillomatosis. هنلاقيها في الكتاب مكتوبة بشتى الطرق. This is the most important point because this is the element that may undergo malignant change. It is a precancerous condition. Epitheliosis, solid epitheliosis أو atypical ductal hyperplasia. كل دي أسامي للcomponent اللي بيأجرافيت الفايبروسيستيك disease and may turn malignant. زي ما اتكلمنا قبل كده fibroadenoma no malignant risk, but the fibrocystic disease, because of the high estrogen level, the patient is at risk to develop breast cancer. Fibroadenomatous change may occur also within the tissues of the fibrocystic area. Next. Fibrocystic disease is a disease that occurs in the middle of the breast tissue. زي ما شفنا duct papilloma مثلا is near the nipple opening, but the fibrocystic disease is usually deep inside the parenchymatous tissue of the breast. Next. Here are the components of fibrocystic disease. You see cysts, yes. You see some glands that are lined by pinkish cells. هنشوفها الأوضح في السلايدز اللي بعد كده. هنشوف حتت فيها solid epitheliosis. هنشوف fibrous tissue in the stroma, cystic dilatation in many of the ducts. نوضح أكتر. Next. Okay. This is the apocrine metaplasia اللي اتكلمنا عليه because it is a modified sweat gland. All glands that secrete something to the outside are lined by these types of apocrine metaplastic cells. بتلاقي cytoplasm is deeply pinkish due to the secretory material, presumably in the breast it's milk, and this is part of the fibrocystic disease, apocrine metaplasia. برضو مش هي دي اللي بتقلب malignant. Next. Yeah, here is a solid part which is called solid epitheliosis or atypical hyperplasia. Cysts, yes. Adenosis, yes. Fibrous stroma as well. But there is this large central part which is solid. It is formed of solid proliferation of atypical ductal cells. هنا بقى this area is at risk to develop into cancer. هيبتدي في الأول بدكت in situ, ductal carcinoma in situ, and then invasive cancer. So at this stage, this lady is at risk to develop breast cancer because she has fibrocystic disease with a solid component, which is the atypical ductal hyperplasia. Next. This is another area where you see some cysts, some ductal hyperplasia, and some stromal fibrosis, but no epitheliosis. Next. So, fibrocystic disease is a disease that may transform to malignancy, which means that this lady, one day she has no cancer, but the other day she has cancer. It does not happen overnight. It takes months and sometimes years for anything like cancer to develop. Before the cancer develops, there's an era which we called a precancerous condition. How can we expect certain lady to be exposed to cancer? We call this breast cancer risk factors. بمعنى إنه she has some factors in her breast that will make her more amenable or more exposed to develop breast cancer. What are these factors? اتكلمنا على شوية منهم، بس هنتكلم على حاجة مهمة تاني دلوقتي، family history. We all heard about families that have many cases of breast cancer. تيجي الست في العيادة تقول أنا والدتي كان عندها breast cancer، أو خالتي أو عمتي، أو أي حد من جدتي whatever. Family history is very important because, as you know, any disease or any cancer is genetic in origin. يعني it is developed due to some genetic change. So what are the genetic changes in the breast that can cause cancer? في عندنا two genes جدا. Breast cancer gene 1 and breast cancer gene 2, or short BRCA1 and BRCA2. These are now very famous. People are seeking to test them to see if they are exposed or more liable to cancer or not. These two genes normally are found in the breast because they protect the breast from genetic disorder. بمعنى if any trauma occurs in the breast or if any high level of estrogen developed in the breast, these genes will work out to eliminate any genetic malformation by killing the cell that is damaged or mutated or has a malignant potential. So, what happens? Now, if these genes are not working properly, these genes themselves are out of function, we call loss of function, then they will not protect the breast if any
دكتور
change occurs. في حاجة ثانية؟
يا دكتور
دكتور صوت
الصوت
حضرتك
ميت.
بيروح وبيرجع.
صوتي ايه؟ قول تاني. الصوت ضاع.
صوت حضرتك بيروح وبيرجع، يعني مش عارفة المايك مثلا بعيد أو كده، مش عارفة.
هحاول أعيد الحتة اللي فاتت دي تاني، البريست ريسك فاكتورز.
تمام.
اوكي. دي حاجة بره ايدي الحقيقة، لأن this is the IT بقى. أنا نفس البوزيشن، أنا ما غيرتش أي حاجة. Anyway, let's hope it will go away. So risk factors of the breast will include breast cancer gene 1 and gene 2. These genes are protective for the breast from any mutated change, but if they themselves have lost their function, what we call loss of function, then they will not protect the breast from mutational changes and cancer may occur. These genes, if they are lost or mutated, then probably they will be inherited by the second generation. يعني الأم تورث genes that are mutated or with loss of function والبنت تورثها لبنتها وهكذا. That is why they sometimes say that breast cancer runs in certain families because they inherit each other a mutated form of breast cancer genes that are supposed to be protective, but they lost their protective value. أدي أول risk factor ممكن يعمل لنا breast cancer. What is the second? We talked about fibrocystic disease. Why? Because of the high estrogen level and because it causes what is known as epithelial hyperplasia, which may undergo dysplasia, after dysplasia, carcinoma in situ, and then invasive cancer. A high estrogen is very hazardous to the breast. Yes, the breast works on the level of estrogen, but if it increases more than what's needed, then it is hazardous. Any exogenous estrogen, including contraceptive pills, because contraceptive pills are just some estrogen products that the female will take to prevent ovulation from the ovary. هنيجي للموضوع ده لما نتكلم في الفيميل genital و how this affects the ovary and ovulation. But just to know that high estrogen level, sustained high estrogen level is hazardous, including those high level of estrogen in the contraceptive pills. Last effect, which is again very rare, but it can occur during wars, ionizing radiation. So what are the risk factors for breast cancer? We can test for the breast cancer genes, or we can excise the fibrocystic disease before it causes cancer, or avoid the intake of high estrogen by whichever source. And lastly, avoid, of course, ionizing radiation. By this, we decrease the risk potential for any lady having these factors to develop breast cancer. Next. So, unfortunately, one factor worked out and it caused cancer. Again, as we said, there is this era of precancerous conditions. If we discover the lady at that stage, we can help her to get rid of the cancer. As we said, high estrogen, just stop the estrogen intake. لو بتاخد contraceptive pills, you can change to another contraceptive device. Loop or anything else. Fibrocystic disease, we can excise it surgically. Milk retention, we always avoid the milk retention in lactating ladies. Duct papilloma, it does not usually change to malignant, but if it is there, it has to be excised. And last, what we talked about, the genetic predisposition of familial breast cancer that runs in certain families. These are the precancerous lesions. Next. The WHO has classified breast cancer into two main subcategories, the non-invasive or carcinoma in situ and the invasive carcinoma. لسه طويلة جدا. All you need to learn is the ductal carcinoma in situ. The most important one that we see usually is called comedo carcinoma. هنشوف صور. You have to see the photos. The types of ductal carcinoma in situ, it means that the malignant cells are still inside the ductal system. They did not invade the stroma. Comedo type, papillary, micropapillary, cribriform, and so on. And this is the ductal in situ. We also have lobular in situ. لو نفتكر يا جماعة, the breast is formed of two components. The secretory component, the lobules, and the conveying system, the ductal. But unfortunately, the tumors that arise from the ductal system is far more frequent than those that develop from the lobules. So intraductal, ductal carcinoma in situ, and lobular carcinoma in situ. These are the two non-invasive or ductal carcinomas in situ. On the right side, invasive carcinomas. The most important and the most frequent that we come across every day in our practice is the duct carcinoma. It forms more than 85% of all invasive carcinomas of the breast. في هنا لستة طويلة, lobular, medullary, mucinous, Paget's, and so on. You have to learn these names only by name. Like we go deeply into the ductal carcinoma because it's most important and it is frequent. So now we learn that breast cancer is either ductal carcinoma in situ or comedo carcinoma or lobular in situ, or on the other hand, invasive carcinomas. The most important is the duct cell carcinoma arising from the duct.
دكتورة ما فيش صوت.
طب ما فيش صوت ازاي؟ مش سامعيني خالص؟
لا بيروح ويجي يعني في الحتة الأخيرة.
احنا قلنا هحاول ان انا اكرر كل سلايد تقريبا علشان الحظ، يعني مش عارفه اقول ايه. ductal carcinoma in situ when the tumor is inside the ducts, an invasive carcinoma when it invaded the ductal or the lobular system and infiltrates the stroma. Next. شويه صور مش عايزه احط الكلام. Intraductal ادي ducts. They show malignant cells within the ductal system, but the surrounding stroma is free. فوق خالص هنلاقي solid type. اللي تحتها هنلاقي البابيلاري. أظن واضح المنظر. هنا بقى الفرق ما بين دي وما بين البابيلوما إنه يمكن بالماجنيفيكيشن دي ما تلاحظوش، لكن البابيلوما is lined by benign cells, but the intraductal papillary carcinoma is lined by malignant cells. اللي تحت خالص بقى الكوميدو carcinoma, the very large duct that is dilated and showing central necrosis. الحته البينكش الهايلاين اللي في النص دي necrosis is the most aggressive type of them all, and it is the most common type that we see. Comedo carcinoma. اللي جنبها بقى اللي عامله زي المحرمه, this is the cribriform intraductal carcinoma. كل دول جوه الدكت. Several morphologic variants, but they are all intraductal. في الناحية اليمين. دول types of in situ carcinoma. Next. Grossly, this is how a malignant tumor looks like. It is ill-defined, non-capsulated, and it infiltrates the surrounding tissues. So we expect this tumor to be mobile or fixed. طبعا fixed. And that's how we can, حتى by palpation, we can differentiate between a benign tumor اللي هو بيجري تحت الإيد أول ما نمسكه اللي سميناه الماوس of the tumor, freely mobile, and this malignant tumor which is infiltrating the surrounding tissue because there's no capsule, and so it is fixed to the breast tissue. The benign tumors, as we said, they are firm, rubbery زي الأستيكة كده, إنما malignant tumors are hard because of the reactive fibrous component فيهم. Hard and gritty, يعني تقطع زي ما تكون بتقطع في حاجة خشب. Okay, so this is the gross appearance of a malignant tumor. The characteristic features بتاعتها إنها usually large in size, ill-defined, non-capsulated, and gritty, hard on cut section. Next. Another examples of malignant tumors. Some may be small, some may be very large. But again, they are all non-capsulated and gritty on cut section. Next. Duct carcinoma. The ducts here are lined by malignant cells. They are crowded back to back. فيهم pleomorphism, فيهم hyperchromasia, فيهم كل ال features of malignancy. So this is duct carcinoma. Next. Should we grade the tumor? Definitely, because there are low-grade tumors and there are high-grade tumors, and it differs in the prognosis and the management of the patients. The tumors that mimic or are similar in morphology, like the normal or the benign component, are low-grade, grade 1. You see the ducts here are well-formed. They form tubule structures, and therefore they are more of a low-grade tumor because they mimic the normal appearance of the ducts. So that's grade 1. Now we move to grade 2. Here, the ducts are being a little bit irregular, ما هماش شكل البناين أو normal خالص. They are still lined by malignant cells, and these malignant cells starting to show some nuclear pleomorphism. Now we go down to the grade 3. تقريبا no tubule or duct formation. They are just forming groups of irregular sheets of cells with high hyperchromasia and nuclear pleomorphism. So breast cancer is subdivided biologically into those that are of low biology, grade 1, intermediate biology, grade 2, and lastly, grade 3, the most aggressive of them all. We expect those that are low grade to behave in a less aggressive way. That means the tumor does not grow as rapid and it might not metastasize early. وطبعا العكس في high grade tumors, they grow much faster and they tend to disseminate into the surrounding tissue, the lymph nodes, and the blood, as we shall see. Next. The other subtypes that are much less frequent include the Mucinous Carcinoma and the Paget's disease of the nipple. Malignant cells here are invading the epidermis in what's called Paget's disease of the nipple. ما بنشوفهمش كتير التيومرز. Next. Lobular Carcinoma. Here the lobules are malignant and they are infiltrating the surrounding stroma. Medullary carcinoma is a tumor that forms solid sheets of malignant cells, no tubules, no glands, no ducts, just solid sheets infiltrated by small mature lymphocytes. دول برضو are rare tumors that we do not come across. Next. Now, we come to a very important subject, hormone receptors. We said that the breast is an estrogen-dependent organ. في estrogen بس طبعا بالكمية المودريت المعقولة needed. Once estrogen is high or is increased, then there is exposure to a risk factor. Some tumors will be estrogen responsive. Some others will be estrogen non-responsive. طبعا أعرفها إزاي؟ By morphology ما نقدرش نعرف. So this patient of breast cancer, will she get anti-hormone therapy or chemotherapy? If the tumor is of the type that is estrogen positive, that is, it responds to estrogen, then we can give this patient anti-estrogen drugs. Nolvadex بقى والحاجات اللي بنسمع عنها دي كلها. If the tumor is not estrogen responsive, it lost the receptors, therefore it will be estrogen negative. So we cannot give that patient anti-estrogen therapy. She will only get chemotherapy. طيب مين بقى العيان اللي هنديله anti-estrogen ومين العيانة اللي هنديها chemotherapy? We test that by what is called immunohistochemical tests. It depends, it really is about an antigen-antibody reaction. If we give an antibody and it responds and it unites with the estrogen to form a visual color, then we know that the estrogen is there. But if we give the antibody and it does not find any estrogen, and so no antigen-antibody reaction occurs, no coloring agent will be formed, then we know that this tumor is not estrogen sensitive. We can test that by what is called immunohistochemical test. We give antibody against the estrogen, and if estrogen is present, it will unite to form an antigen-antibody reaction that has a brownish coloration. تحت الميكروسكوب we can see. We cannot see the antibody, we cannot see the antigen, but we can see the union of the antigen and the antibody with the coloring agent, and then it will give us the brown coloration. So hormone receptors, if positive, then this patient will respond to hormone therapy. We can give her anti-estrogen. But if this tumor is not sensitive, then she will be given chemotherapy. Okay, next. Here are the examples. Tumor estrogen receptor positive. The lady above will receive anti-estrogen. كل العيانين بيفضلوا ان هم ياخدوا هرمون ثيرابي عن ما ياخدوا chemotherapy, because as we know chemotherapy has a lot of hazardous effects on the body. So if we can avoid chemotherapy, then it will be much better for the patient to get anti-hormone therapy. So ادي immunohistochemistry. Okay, estrogen positive or estrogen negative. Next. ليه? Because those that are high on estrogen and progesterone are those that will be high on response to anti-hormone therapy. كل ما كان الهرمون، يعني ممكن يا محمود نرجع تاني للسلايد اللي قبل كده. If you see, we've put an estrogen strongly positive here, and the one down there is weakly positive. So this, the strongly positive will respond much better to hormone therapy, while those that are weakly positive will respond less favorably. طبعا, if it is totally negative, we will not give hormone therapy altogether. Next. So the more or the higher the content of the estrogen in the cells, the better will be the response. وكل لما قل طبعا كل response ما يبقى أوحش. Some people may get combined hormone and chemo just to synergize each other, or to help each other in combating the disease. بس ده مش مطلوب منكم قوي. Next. How does breast cancer spread? And it is almost the same as any other tumor in the body that will spread. Three main devices, either local, lymphatics, or blood. بس في كل organ we have to describe local going where, lymphatics to which group of lymph nodes, and blood to which organs. Local in the breast, it will either expand to ulcerate through the nipple, or through the skin in general, or the deep fascia, or the pectoralis muscle, deep margin. So it can either ulcerate through the skin or deeply. It will cause fixation and skin ulceration and nipple retraction. مهم قوي حتة nipple retraction, because this is one of the clinical signs that we can anticipate malignancy, because of the fibrous component that pulls down the nipple inwards. The local spread. Now we come to the lymphatic spread. The group that drains the breast is, of course, number one, the axillary nodes on the same side. فلو breast cancer on the right side, so the right axillary nodes will be the first station to receive metastasis. Axillary nodes. Then the supraclavicular, which is another step further. It means more spread towards more distant group of lymph nodes. The internal mammary, this will cause some dermal lymphatic emboli. By the way, if you mention internal mammary or supraclav without mentioning the axillary nodes, that is wrong. You have to mention the axillary nodes first, because they are the first station to receive the metastasis. So this is lymphatic spread. So it really matters whether the tumor has metastasized in the lymph nodes or not yet. And this affects the stage زي ما هنشوف بعد كده. Now the third component is the blood. And once the tumor cells get into the bloodstream, it can go almost anywhere. But there are organs that are more famous to receive metastasis, and these are للتسهيل the 2 L's and the 2 B's. the liver, the lung, the bones, and the brain. It can go anywhere else, the suprarenal, anywhere. Now, the local, lymphatic, and the blood. This will affect the stage of the tumor, whether the tumor is still in an early stage or a late metastasizing, disseminating disease. This is a lymph node metastasis. So it means that this lady has got a breast cancer that already metastasized to the lymph nodes and even towards the capsule of the lymph node. Next. Or it can spread along the nerves. And here we can see a nerve bundle with a tumor inside the nerve sheath. So we call this perineural invasion. This really causes a lot of pain naturally, because if it is a sensory nerve, it is going to cause pain. But more importantly, it is disseminating. Perineural invasion. Next. Breast disease in children is a very rare occurrence. I don't usually mention it, but just for your knowledge, fibroadenomas usually from 12 to 20 years, not before puberty. زي ما قلنا إن fibroadenoma is for young adults, juveniles maybe, but below 12 it's very rare. Sometimes there is what we call virginal hypertrophy in ducts and stroma around the age of puberty. But carcinoma in children is extremely rare, and we should not even mention it. في مشكلة؟ Next. Next, yes. Now, male breast is another story. بنشوف male breast, yes, but it is very rare. Again, not extremely rare, but it is 1%. That is, for 99 cases of female breast cancer, we see 1 case of male breast cancer. نتكلم الأول على الجاينيكوماستيا. Gynecomastia is hypertrophy of the male breast. لو ناخد بالنا من الاسم, gyna means female, mastia means breast. So it is a male having the breast of the female like. It is due to hypertrophy of the ducts and the surrounding fibrous tissue. ناخد بالنا ان الميل breast has only ductal system, no lobules in the male breast, because no need to secrete no milk. فيبقى إذن the only tumor that can be affecting males will be the duct carcinoma and never the lobular carcinoma. هنا ايه اسباب بقى الهايبرتروفي of the male breast اللي هو الجاينيكوماستيا. Also the males can be exposed to high estrogen, either internally, the nature of the body chemistry, or during the intake of some drugs like those that treat heart conditions, digitalis and so on, or liver cirrhosis. Why? Because liver is a very important organ in our body that is responsible for the catabolism of all the hormones and the enzymes and the drugs and all that. If the liver is cirrhotic and thus out of function, then the hormones and the enzymes will not be catabolized and will stay to give high level in the body, including their hazardous effects. في الآخر خالص في حاجة اسمها feminizing adrenal tumors. لما هناخد إن شاء الله endocrine system هيبقى فيه lectures على suprarenal gland. One of the tumors in the suprarenal gland will secrete high estrogen. فكل دول أسباب للجاينيكوماستيا or hypertrophy of the male breast. Next. Now, male breast cancer, as I said, is rare, 1%. It is similar to female cancer, but only the ductal subtype. Unfortunately, it is rapid in spread to the lymph nodes. Lay? Because the parenchyma of the male breast is minimal, is much less than the parenchyma in the female breast cancer, breast tissue, which has surrounding fibrous tissue component and fat and so on. So the spread is not as rapid as that of the male breast. And also it can show rapid spread to the lymph nodes. It can metastasize early, again due to the minimal tissue between the breast and the neck. كده خلصنا؟
دكتور صوت حضرتك راح.
لا أنا مش بتكلم دلوقتي، أنا بقول next. أوكي، إحنا كده خلصنا البريست يا جماعة. سؤال أو اتنين بسرعة قبل ما نبتدي في السيرفكس. إذا ما كانش أنا ممكن بس أراجع بسرعة. إحنا اتكلمنا النهاردة على 3 حاجات مهمين اللي هم البيناين تيومرز اوف ذا بريست، فايبروادينوماز مثلا والدكت بابيلوما. بعدين اتكلمنا على الفايبروسيستيك ديزيز واهميته وانه بري كانسرس. وبعدين اتكلمنا على البريست كانسر، كوميدو كارسينوما انسايتو وداكتال كارسينوما انفيزيف بكل ما فيها من جريدز وستيج وسبريد و كل الحاجات اللي قلناها النهارده مهمه، لان انا من نفسي I have excluded الحاجات اللي ما بنشوفهاش كتير وملهاش اهميه كبيره. فيبقى اذا نهتم بكل اللي اتقال النهارده في البريست. When you are ready we can start with the cervix.
تمام يا دكتور.
يلا. Okay. Next, cervix. برضو أنا I have chosen the most important thing في السيرفكس وهي cervical intraepithelial neoplasia أو short CIN. إيه CIN ده؟ cervical intraepithelial neoplasia. فالاسم بيقول إيه؟ إنه the lesion is still within the epithelial component and it did not break the basement membrane. خطورتها ايه؟ خطورتها ان الابيثelial changes that occurs in the mucosa of the cervix will undergo dysplastic changes from mild to moderate to severe until it forms the carcinoma, cervical carcinoma in situ, and then the invasive carcinoma. So cervical cancer is always preceded by a stage of cervical carcinoma in situ. However, not every case of cervical intraepithelial neoplasia will progress to form cancer. Next. The history is very long. أنا يعني حطيت الجدول ده علشان تفهموا الكونسبت بتاع ال early detection. The early detection is a very very strong survey موجود في كل حتة في العالم by cervical smears أو pap smears أو مسحة عنق الرحم. Every female above the age of 12 anywhere else in the world will have to undergo periodic checkup for pap smears to see if any dysplastic change. Cervical intraepithelial neoplasia is graded into grade 1, 2, and 3. For each stage, it takes many years for the tumor or the lesion to progress from one stage to the other. CIN 1 and 2, the lady will be around 22 years, sometimes younger. In the Western world now, sex is open and they undergo sexual activity quite early in their career or in their life. But it takes 7 years to develop from cervical intraepithelial neoplasia 1 and 2 up to grade 3. And this progression occurs in only half of the cases. Now, if you move to cervical intraepithelial 3, then the mean age is a bit higher, 22 years of age, and it takes again another 7 or even 10 years to produce cancer. The cancer then is around the age of 41, and it takes 2 years to invade in all the tumors. Once it is microinvasive, it will form invasive cancer in all the cases. هنا بقى إيه الغرض من الجدول ده؟ This shows the very long time for a female to show that she has risk for cervical cancer. And for that, you can definitely form a project or a screening program to eliminate or to eradicate cervical cancer. طبعا in the Western world, they use the vaccination nowadays. كل الفيميلز at the age of 12 or 15, they get the vaccines for cervical cancer. لكن if not, then you know that females will have enough time to detect those dysplastic changes and to eliminate or to prevent the occurrence of cervical cancer. وفي العالم دلوقتي cervical cancer is being decreased because of the application of mass screening and prevention. Next. This is an example of cervical intraepithelial neoplasia. The epithelium is quite thick, and it shows the upper part having those vacuolated cells, clear cytoplasm. We call these cells choliocytic cells, and they harbor the causative organism of the cervical intraepithelial neoplasia, namely the human papillomavirus, plays an important part in cervical carcinoma. But here it is restricted to the upper third of the thickness of the epithelium, and thus this is cervical intraepithelial grade 1, stage 1. Next. Here again, low-grade CIN, in which only about 1/3 up to 1/2 of the epithelium shows the choliocytic cells. The photos down there show higher CIN, in which more than 2/3 of the thickness of the epithelium shows dysplasia, and thus this is called CIN 2 or 3. So they start by the upper third, and then the half of the thickness, this is CIN 2, and the whole thickness, or more than 3/4 of the thickness, this is CIN 3. Low-grade CIN, and then moderate and marked. Next. Again, moderate CIN, half thickness is dysplastic, صورة على اليمين, high grade, in which the whole thickness is being diseased, affected by the human papillomavirus, causing the dysplastic changes, the ectocervix. Next. Now, more and more, the changes here are quite apparent that they are malignant looking, but they are within the basement membrane, not affecting or not piercing the basement membrane and not causing invasion. This is called carcinoma in situ. So we move from mild dysplasia, or CIN1, to moderate dysplasia, CIN2, or marked dysplasia, or CIN3, and then sets cancer, but in situ, carcinoma in situ. Now, once the disease or the cells, malignant cells, puncture the basement membrane and invades the surrounding underlying tissues, this is called invasive squamous carcinoma. الصورة اللي تحت. الصورة اللي فوق carcinoma in situ, respecting the basement membrane. But الصورة اللي تحت, invasive squamous carcinoma, destroying the basement membrane and infiltrating the surrounding tissues. Next. So again, زي ما اتكلمنا في breast, what are the risk factors for developing cervical cancer? Definitely early age at the first intercourse. معناتها إن the lady is having an active sexual career or life. She is performing sexual acts, and this will expose her to the virus. She might have multiple sexual partners. That's again another cause. Or a male partner with multiple previous sexual partners. يعني معناتها هنا الconductivity عالية. يعني إنه viral transformation or the effect of the virus from one person to the other is high, causing up to CIN3 or marked cervical dysplasia. Human papillomavirus is a virus with many subtypes, more than 60. But what we care to learn is the malignant ones, or the ones that are potentially causing malignancy. وهنا الأرقام دي لازم تحفظوها. 16, 18, 31, and 32. Those 4 subtypes of human papillomavirus will cause cervical cancer. Other types may form only benign condylomas, benign lesions, اللي هم ايه type 6 and 11. So هنا بقى the mass screening is very beneficial. If a lady is being monitored and we discover that she has some kind of cervical dysplasia, whether it is mild, moderate, or marked, then she has to be treated to prevent the transformation of this dysplastic cells to be malignant. Or بس هنا يمكن عندنا مش في مصر منتشر قوي الhuman papilloma virus subtype by PCR. We can detect the virus. If it is positive for 16, 18, 31, 33, then this lady is at very high risk to develop cervical cancer. While if the types are 6 or 11, then she will only be at risk to develop benign conditions. So these are the risk factors. Some we get from the clinical history, if she starts her sexual career early, or she is having multiple sexual partners, or that more morphologically by a pap smear, then she is having some kind of a dysplasia that we can detect by a cervical smear, or we can detect the type of the virus by PCR and see whether it is an oncogenic type of a virus or a benign one. All these are risk factors and can be preventable. We can prevent the occurrence of cervical cancer in such a stage. Next. Now, cervical cancer occurs because of the persistence of precancerous conditions that were not treated. So persistent chronic cervicitis harboring the virus will develop cervical dysplasia or CIN. And the grades are 1, 2, and 3, moderate, mild, moderate, or severe. Lastly, carcinoma in situ. When we see all these, we know that the lady is having a precancerous conditions to the occurrence of invasive carcinoma. Next. Now, for some reason, it was not stopped, it was not detected, it was not prevented, and this is cervical squamous carcinoma in situ. Clearly, the ectocervical epithelium, the whole thickness of which is being replaced by malignant cells. The cells are highly pleomorphic, loss of polarity, hyperchromasia, كل الcriteria of malignancy within an intact basement membrane. So we call this squamous carcinoma in situ. And it is the sequelae of the mild, moderate, and marked dysplasia due to human papillomavirus. Next. Now, more advanced stage is when the carcinoma in situ breaks the basement membrane and invades the surrounding tissue. It will cause what is known as invasive carcinoma. Grossly, how do they look? The gross appearance of cervical cancer is either a fungating nodular mass or a cauliflower mass or a malignant ulcer. And we all know the criteria and characteristic features of any malignant ulcer: necrotic floor, everted edges, and indurated base. Or it can form an infiltrating tumor, not ulcerating and not cauliflower, but directly invading deep tissues. So fungating, ulcerating, or infiltrating. Under the microscope, because of the ectocervix being lined by squamous epithelium, so naturally the tumor will be squamous cell carcinoma. The grades بالضبط زي ما قلنا في البريست: low grade, moderate, or high grade. هنشوف الexamples. Or it can be adenocarcinoma. طب هيجي الادينوكارسينوما منين؟ From the underlying endocervical mucus glands. في mucus glands كتيرة في الcervix for the sake of lubrication. These glands may also undergo malignant transformation through the human papillomavirus bardo, causing adenocarcinoma. But this is rare, much less frequent. What we normally see usually في الcervix is the squamous variant of the tumor, squamous cell carcinoma. Rarely we can see a mixed adenosquamous when it affects the overlying mucosa of the cervix and the underlying glands, or يحصل tumor metaplasia in which the squamous shows some glandular features. So it is a mixed adenosquamous carcinoma. Next, some photos. This is a fungating cauliflower mass of the cervix, and the cervix is opened just to reveal the tumor. Multiple nodules, they are cauliflower masses, hemorrhagic or necrotic, all criteria of malignancy. Next. Again, this is an example of invasive squamous carcinoma. With very high anaplasia, mitosis, the arrows form pointing at some mitosis. Next. If it occurs in the endocervical glands, we see here the arrow pointing to the point at which the malignancy occurs. الناحية الشمال is the normal. The cells are producing mucin, basal regular nuclei, and suddenly the change to adenocarcinoma. This is adenocarcinoma in situ. Next. And then it breaks the basement membrane and invades surrounding stroma, forming irregular malignant glands. Frankly, a case of invasive adenocarcinoma. Next. How does cervical cancer spread? نفس اللي قلنا في البريست: direct, lymphatics, and blood. But here you have to describe the direct. It can go downwards to meet what? The vagina is there, so it can invade the vagina. Or anteriorly to find what? To the bladder and the ureters, anteriorly. And it may form a vesicovaginal fistula. A fistula is an abnormal connection between two organs. So by the connection, it will form this fistula. Posteriorly هتروح هتلاقي ايه؟ rectum. So it can again form a rectovaginal fistula or a rectocervical fistula. This is posteriorly. If it goes up, then it will find the endometrium, and it can invade the endometrium going up through the cervical canal. So it's downwards, anterior, posterior, upwards, anywhere. This is direct spread. Lymphatics, هنا بقى طبعا مش axillary, so it goes to the iliac nodes or the lumbar or the sacral nodes. Again, you should mention those by name. Blood, again, زي ما قلنا في البريست, lung, liver, bone, brain, whatever. So this is the spread for cervical cancer. Next. The stage is how far did this tumor spread in the body. Stage 0, when it is confined to the cervical intraepithelial component. It's called carcinoma in situ. Stage 1, if it breaks the basement membrane and invades the cervix, the cervical tissue only, but no other extension. Stage 2, if it invades the upper 2/3 of vagina. Stage 3, if it reaches the pelvic wall or the lower third of the vagina. And lastly, stage 4, when it reaches other organs in the vicinities like the urinary bladder, rectum, even if it did not show any lymph node metastasis. That is still a very advanced stage 4 disease. فناخد بالنا من السؤال بيقول ايه؟ grade ولا spread ولا stage؟ ناخد بالنا. اوكي كده خلصنا. next. شوية صور بقى. This is an example of invasive carcinoma. Here it's confined to the cervical tissue. وفيها هنا معاها لايومايوما كمان. Next. Here is an advanced, locally advanced cervical carcinoma. Again, a cauliflower fungating mass reaching the vagina. Next. And here are the very late stages in which it invaded the bladder anteriorly and the rectum posteriorly. خلاص كده انتهت. Okay, the grade. هنا بقى الجريد غير الستيج. أنا قلت ناخد بالنا. الجريد is how biologically the tumor is active. Low grade, and the more it forms keratin, like the normal, the lower the grade. So this is well differentiated. Grade 2, if it is moderately differentiated, forming some keratin but not much. And grade 3, when it's poorly differentiated and the keratin is minimal. نشوف الصورة. Here, grade 1, a lot of keratin. This is a low-grade tumor that spreads slowly. Grade 2, some keratin is there, moderate in amount, and the photo down there is minimal keratin, and the cells are looking more aggressive, more pleomorphic, and more hyperchromatic. Grade 1, grade 2, and grade 3. أنا أخرتكم معلش شوية، لكن أنا فضلت إن أنا نعمل البريست مع السيرفكس عشان ما ندخلش في رمضان ونسيبكم للمحاضرات التانية. المحاضرة عندكم متسجلة بقى، تقدروا تشوفوها في أي وقت. شكرا.
شكرا لحضرتك يا دكتور.
يعني ما فيش محاضرة الأسبوع الجاي؟
لا خلاص، احنا كده احنا ضمينا السيرفكس مع البريست علشان نخلص، وبرضه نرجع بقى للدكتور محمود.
تمام. طب يا دكتور احنا